All right, welcome to this explainer. Today we're diving into one of the most visually dramatic presentations in all of clinical hematology, primary myelofibrosis. We're going to build our understanding of this fascinating, yet really severe disease entirely from first principles. We'll look at the core lesion that forces the bone marrow to literally scar itself to death and see exactly how that one mechanical failure triggers a massive cascade of systemic consequences. Let's get into it. To start things off, I want you to picture a patient's spleen that has grown so unbelievably massive, you can actually see it before you even touch the abdomen. Imagine an organ visibly crossing the midline, reaching all the way down into the right iliac fossa. I mean, this isn't just a spleen quietly doing its normal job a little too enthusiastically, right? And that leads us straight to a core question. What actually causes an organ to completely abandon its day job and launch a full-blown emergency rescue mission? Because honestly, that is exactly what's happening here. We really need to frame this dramatically enlarged spleen not as some random isolated symptom, but as a desperate biological backup plan. The spleen has essentially been drafted into an emergency role that it was never designed for. Okay, let's break down this chain reaction right from first principles to see why that backup is even needed. Primary myelofibrosis is a myeloproliferative neoplasm, and it all kicks off with step 1, a clonal mutation of a haematopoietic stem cell. That sets off step 2, an abnormal proliferation of megakaryocytes in the bone marrow. By step 3, those abnormal cells start dumping out inflammatory and fibrogenic cytokines, which, of course, leads to step 4, where marrow fibroblasts get heavily stimulated. And finally, step 5. The normal healthy blood-producing architecture of the marrow is progressively replaced by dense reticulin and collagen scarring. The marrow is literally scarring itself into total failure. Now, this leads us to a really obvious but super important question. If the body's central blood factory is completely destroyed by scar tissue, how does the body compensate and survive? I mean, when the bone marrow shuts down, the body has to find a workaround fast. Enter extramedullary haematopoiesis. The body reacts to the failing marrow by basically reactivating blood cell production outside the marrow, specifically in organs that used to do this job during fetal development and still have that latent capacity. So the spleen takes over as the dominant site for this compensatory production. But because it's suddenly trying to do the job of the entire skeleton's bone marrow, it swells up dramatically. And that's what gives us that massive and often really painful splenomegaly we just talked about. But here's the catch. The spleen is actually a pretty terrible substitute for healthy bone marrow. And that brings us to the profound anemia that really defines this disease clinically. This anemia isn't just from one thing, it's a triple threat. First, you've got ineffective marrow production cutting down red cell output. Second, that gigantic spleen actually traps and destroys the red cells that are produced, which is called splenic sequestration. And third, you have bleeding caused by thrombocytopenia or low platelets, which is super common in advanced disease. When you stack all three of those together, it makes total sense why these patients are so incredibly pale, exhausted, and just depleted of healthy red cells. And as you can imagine, carrying around a spleen that massive hurts. But the abdominal discomfort isn't just one single issue. Let's look at the 4 distinct mechanisms going on here. First, there's just the sheer mass effect of this giant organ crushing the other organs around it. Second is splenic infarction. This happens when the spleen grows so fast its own blood supply can't keep up, causing parts of the tissue to literally die off. Third, we see portal or mesenteric vein thrombosis, which ties into the overall risk of blood clots in myeloproliferative diseases. And finally, hyperuricemia with renal stones, which happens because of the massive cell turnover from that highly proliferative marrow. Okay, so how do we officially lock in a diagnosis? Let's do a quick run-through of the WHO diagnostic criteria. To diagnose overt primary myelofibrosis, you need to hit all 3 of the major criteria, plus at least one of the minor ones. You absolutely must prove megakaryocytic proliferation and fibrosis. You have to exclude other myeloid neoplasms like essential thrombocythemia or CML, and you need to find a clonal marker like a JAK2, KLR, or MPL mutation. Then you just need one minor finding to clinch it. Things like unexplained anemia, a high white count, palpable splenomegaly, elevated LDH, or a leukoerythroblastic picture on a blood smear. And speaking of blood smears, this whole mechanical struggle leaves behind some incredibly clear physical evidence. When you look at a peripheral blood smear, you'll see these classic teardrop-shaped red cells. They're literally physically deformed as they desperately try to squeeze their way out through the tight, scarred architecture of the marrow. And if you try to do a bone marrow aspiration, well, you get what's famously known as a dry tap. You pull back on the syringe, and absolutely nothing comes out. The fibrotic scar tissue is just so dense it won't yield any liquid aspirate at all. Now, quick word on the JAK2 mutation I mentioned earlier. It is absolutely vital to remember that while the JAK driver mutation shows up in about 60% of primary myelofibrosis cases, its absence definitely does not rule the disease out.
A full 40% of patients are going to be JAK negative. This is a massive distinction from polycythemia vera, where JAK is there like 95% of the time, and if it's missing, you really need to rethink your diagnosis.
Right, so understanding these markers helps us build a picture of patient risk. Historically, median survival is roughly 5 to 7 years from diagnosis, and we track some very specific adverse prognostic factors: being over 65, having a hemoglobin below 10, the presence of constitutional symptoms, a high white cell count over 25,000, and a peripheral blast percentage of 1% or more. This is exactly why next-generation sequencing is a total must-have in current practice. It flags not just the primary driver mutations, but the high molecular risk genetic factors that completely dictate how we plan treatment.
And here's a number that really highlights the stakes: 10%. Roughly 10% of patients with primary myelofibrosis will transform to acute leukemia over a 10-year period. It's a severe risk. And specifically, if you see a peripheral blast count of 2% or more, that acts as a major red flag for this elevated transformation risk.
Knowing just how severe this disease is, how are we actually treating it today? Well, the landscape has completely shifted, and we need to contrast the old teaching with the current reality. For decades, the mantra was a one-drug-fits-all approach, using ruxolitinib. It was the first approved JAK inhibitor, and yeah, it worked great for shrinking the spleen, but it notoriously worsened anemia and tanked platelets. Today, the 2024 NCCN treatment guidelines are a total game changer. We're now using highly tailored therapy matched specifically to a patient's individual cytopenias.
So instead of that old one-size-fits-all approach, we've now got 4 distinct JAK inhibitors, each matched to specific patient profiles. Ruxolitinib is still your traditional baseline. Then you have fedratinib, which acts as a high-risk alternative with similar efficacy. But check out the bottom 2. Pacritinib is uniquely designed for patients with severe thrombocytopenia, and momelotinib, which was just approved in 2023, specifically targets the anemia problem directly by inhibiting a receptor called ACVR1, which drops hepcidin levels. It's a much more precise toolkit. I really want to highlight this specific threshold: 50,000 platelets. Before 2022, if a patient's platelet count dropped below 50,000, the older JAK inhibitors basically couldn't be used safely at all. Your hands were tied. Pacritinib was specifically developed and approved to fill this exact gap, finally giving us a safe option for these highly vulnerable patients.
Now, addressing the profound anemia specifically takes a bit of a workflow according to the latest NCCN guidance. First things first, we have to aggressively hunt down and treat any reversible causes. We're talking bleeding, B12 or folate deficiency, or hemolysis. Once you've ruled all that out, then we escalate to targeted anemia-directed agents, things like luspatercept, erythropoiesis-stimulating agents, or danazol. And these are very often prescribed right alongside a JAK inhibitor, rather than swapping it out.
Now, you might be thinking, hey, if the spleen is causing all this pain and destroying all these blood cells, why not just take the whole thing out? Well, it's crucial to know that a splenectomy, or splenic irradiation for patients who can't do surgery, is strictly a last resort for refractory symptomatic splenomegaly. We only go there when all drug therapies have completely failed, simply because the perioperative bleeding and clotting risks are just astronomically high in this specific patient population.
Here's the bottom line, though. While our modern lineup of tailored JAK inhibitors do an amazing job at managing symptoms and improving quality of life, they do not cure the underlying disease on their own. Allogenic stem cell transplantation remains the absolute only option we have that truly alters the natural history of the disease and offers a genuine cure.
So, to wrap up this explainer, I want to leave you with this thought. The next time you encounter a spleen so massive it's visible before you even touch the patient, don't just marvel at how big it is. Ask yourself, what central factory has failed so completely that a backup organ had to step in and take over? And more importantly, has this systemic failure already started tipping towards something even more dangerous, like acute leukemia? Because recognizing this disease from first principles is the absolute key to understanding its trajectory and getting in there early with tailored intervention. Thanks so much for joining me for this explainer.